we move on to another very important topic, that is on immediate access to ART. As we move to 500, it is projected that 86% of people who are presenting to registering in healthcare facilities will have CD4 less than 500. So you will have a huge increase in the number of patients actually accessing ART. So timely access is very important. So we have now Dr. Velipi Okello, who is a medical doctor, holds a master's degree in public health with focus on health management and policy. And she is National ART Coordinator at Swaziland National AIDS Program in the Ministry of Health and has been in this position for quite some time. And Dr. Okello, please.
Thank you for the introduction. So my presentation will be on the MaxART program. MaxART stands for Maximizing Art for Better Health and Zero New HIV Infections. So we're looking at strengthening community and facility-based interventions towards immediate access to art. So this is the outline of my presentation. So we started to have this dream of eliminating new HIV infections in the country in 2010 when we were offered the opportunity to apply for what was called the DREAM Fund, that was under the Dutch postcode lottery, assisted by CHAI. And so we started to think around having such a high prevalence and such a good uptake of ART services. At that time, the question we're asking ourselves is, what will it take to reduce new HIV infections in a small population like Swaziland with the highest HIV prevalence in the world? So at that time, we realized that although our incidence had showing signs of declining, we realized that our prevalence was remaining at a very high level, especially for pregnant women. So we could see that we need to do something a little bit more ambitious. However, there are other issues that we have to think of as we continue, if we want to provide early access or immediate access to art. So the MaxART program was designed since from around 2011, around 2 phases. The first phase being plugging in the leaky cascade in our service delivery, but beginning with community mobilization, because as a national art program, we had not engaged communities very well in order to achieve universal access. So wanted to provide information, testing, treatment and care, and support. And also, we also realized that our work with people living with HIV as a program was not well defined, and we didn't understand quite how they were feeling. So we wanted to hear their perceptions. So within the program, we also incorporated working with people living with HIV and social science studies. We also included epidemiological modeling. In phase 2, we are planning to move towards early access to art for all implementation study. It's going to be a pilot, so it won't take place in the whole country, as I'll explain later. So in the phase 1 initiatives of MaxART, we, like I've said, we're plugging in the leaky cascade along the continuum of care. Most of the activities were already going on through support from other partners, especially PEPFAR-funded partners, and Medicine Sans Frontiers, who had been doing a lot of work in this area. So as MaxART, we introduced sort of strengthened activities such as community mobilization through community-based volunteers, traditional leaders, engaging them in the response to HIV, and also focusing on males, because we realized that males are lagging behind in our service access, and adolescents who we are facing challenges with in adherence support. Other innovative approaches include Fast Track, which we organize communities to identify their own problems in terms of accessing HIV services and design their own solutions within a 90-day period and implement them. And these were mainly focused around how males can access services, including testing and treatment, and how adolescents can be assisted. So these are some of the interventions that were put in place. So the achievements that we've seen especially in the area of mobilizing communities in Swaziland, we realized that we did a lot of mobilization. There were dialogues reaching more than 27,000 people in the forecast area where we'll conduct our pilot study. 570 community events that were especially targeting men, 35 fast tracks where we're encouraging men to go for testing, and people reached through door-to-door visits with information on HIV testing and counseling. And this was echoed, the success was echoed by one of the young chiefs in the country who realized that the importance of being engaged from the start of the program was important for him. And then in terms of testing and art, during that period, as I mentioned before, this success is not only MaxART in this case, there are other partners involved. We realized an increase in HIV testing and counseling, where the target had been set at 250,000. We reached more than 300 tests by the end of 2013, which has already passed our target. And for art, we also targeting to reach 90% of those in need with CD4 350. And so far in 2013, we had reached 83%. And the important area also that we are implementing is involvement of people living with HIV through the working with Global Network of People Living with HIV and SWANEPA, which is the Swaziland National Network of People Living with HIV and AIDS, through the program. And to date, we have worked with them in certain approaches, including positive health, dignity, and prevention research, where the SWANEPA and GNP Plus work together to do a research on the stigma index, just trying to understand what drives stigma among people living with HIV in the country. And it was interesting to note that more than 60% of people admitted to self-stigmatizing, and others were the next was family stigma that they experience. Other areas, human rights monitoring, where SWANEPA is developing a tool that will help us to monitor the rights. This is in relation to health service provision in their facilities and focusing on patients' rights or clients' rights. They will also, in the process of establishing a community advisory board that will be throughout the implementation of the study. The social science research conducted by the University of Amsterdam has helped us to understand the barriers to access to services and retention in care with focus on men and adolescents. So in the second phase, we started with a pre-implementation study by the social science team who were just finding out the perceptions of people living with HIV about different topics, but really relating to treatment as prevention, what they understand about it. And some of the questions asked are shown here. Being willing to start ART on the same day, willing to start ARVs while feeling healthy, or to start ART early to reduce the chance of infecting others. Here we noted that while women were consistently responding to the positive, like answering yes to the first three questions, in the last two, we saw that men had slightly an upper, higher response rates in terms of initiating ART, regardless of CD4, would be a good decision for Swaziland. And should we tell clients of the prevention benefits of ART, it seems that the men felt it was more important for people to be told of the benefit compared to the women. We are yet to understand why as we continue with our study. And then these are some of the experiences in terms of their access to services or their experience with our health services. Two clients who reported that they had not received any counseling, as shown here. And so they were informed that they were HIV positive without proper counseling. And so it just showed us that there were still some gaps in terms of our implementation of HIV testing and counseling, which could probably lead to people not wanting to come back for testing or telling others not to access the services because the services are not that good. So we need to work on this if we are to ensure that we get a good uptake in the early access to art. So the recommendation is that we work on developing a communication strategy for the study, which is going on now. And then the study itself will take place, it's beginning in August. It will take place in this area of the country. This is the northern part of the area that borders South Africa. It's a very rural community, and we just want to understand whether this approach will be feasible, acceptable, and also we look at clinical outcomes, affordability in terms of cost and cost effectiveness, and scalability. What will it take to implement this approach in the whole country as Swaziland? So the design will be a 3-year randomized step-wedge design where 14 facilities in the region, as shown before, will be grouped into 7 steps. So 2 facilities will transition at a time. And at the control phase of that facility, the control stage, they will continue to offer ART based on CD4 eligibility criteria. Everything else will continue to remain the same. And then during the transition point, they'll be assisted by the research assistants to transition to be educated about what needs to be done, to work through the standard operating procedures towards the intervention phase where they will offer ART regardless of CD4 eligibility. So everybody who walks in who is HIV positive will be offered ART, whether they have been on pre-ART or not on ART or just have been tested. But we are only looking at HIV positive adults. We will not include children, younger children here. So as I conclude, in our approach for early access to art, which will begin soon, we would like to make sure that the community-based and facility-based interventions are strengthened. So although MaxART began in 2011, we want to continue with those activities through the early access to art study so that we are able to initiate art for all people living with HIV. And then the MaxART program relies also on the client's perceptions, which we obtain through social science research. So social science research and human rights monitoring will continue into the phase 2 of this program. And it will also be interesting to see what has changed, what will change before the implementation of the program and after we have started to offer people ART early. And would like to ensure that we follow human rights and enable the reduction of stigma and discrimination. So through the monitoring of the stigma index. I thank you.
The session is open for questions. Yes, please. Please introduce yourself.
Yes, Jorge Saavedra, AIDS Healthcare Foundation, Mexico. I want to congratulate Belepi on the presentation on Swaziland, and also to mention that 2 years ago during the International AIDS Conference in Washington, D.C., there were many people, well, not many, but a lot of people arguing that probably newly detected HIV positive people were not going to be willing to start ART in order to protect others. And you are showing us exactly the opposite, that yes, there are people that look like this is not the case, that actually HIV positive people, new detected, are willing to start ART early in order to reduce the risk of transmission, which is, I think, clearly good news.
Shall I go ahead?
Yes, please.
Okay, thanks, Dr. Okello, for a good presentation. I'm wondering, do you know a little bit more about those who are not willing to start immediate ART? Do you have any sort of further information on that group of people?
Okay, so thanks for the questions. Yes, it is interesting to note that people are willing to protect others, so there is that feeling that we need to protect others from HIV infection. So for those who are not willing to start, I just didn't show all the results, but some of the results are about people saying they are not sure. So which means that if you look at the not willing and the ones who are not sure, it was almost half-half, meaning that for us, it seems that people need more information to understand what we really mean by what we are saying. So, but some of the reasons for those who said no, they are not willing to start, some of the reasons is that they were not sure. They are saying that we are struggling with our stocks for ARVs and many issues, long queues, waiting times in the facilities, and they are feeling like they don't want to be part of that. They don't think the system will cope with the burden. So that was some of the reasons why they refused.
Yes. Number 4, please.
My question is somewhat related. Tina Monique James from World Vision International. I was wondering, essentially, what measures do you currently have in place to assess the patient's readiness to initiate treatment? And if you can perhaps expound upon that for us, please.
Thank you for that question. We've realized very earlier on that it's very important for people to be assessed for readiness. So what we are doing is we engaged expert clients who we give a stipend to work with us at facility level. So what they do, they go through a job aid and counsel people on what information they need in order to start ART. So in the end, we always emphasize that they need to record somewhere that patient cancelled and willing to start ART. But this will then be confirmed by the doctor or nurse who is initiating ART, just verbally to ask the patient, did you understand? Do you know what you are going into? Do you have any further questions before they start ART? So it takes us 3 adherence sessions for the patient to be initiated on ART.
Yes, I think it is very important that the importance of preparedness is not lost in this our eagerness to start ART early. And in one of the presentation, we showed that 57% of patients are ready to get the ART on the same day they are tested. There are issues about at least 2 sessions, patient understanding his result, coping up with the result, then preparedness, ruling out opportunistic infection, risk for iris. I think we have to be very careful while talking about, yes, if you don't provide immediate access to ART, there are people who are lost to follow-up in pre-ART also, even among eligible group. So it is very important that we maintain a balance. But very important point that came out from this presentation was about community mobilization. Yes, there is a lot of talk these days on community mobilization and community testing. Otherwise, we are not going to able to detect those people which are asymptomatic, which are not coming to health facilities for interventions. So it is important that we reach out to people in the community. Thank you very much for a nice presentation.